Good morning, my dears. Today, my topic mainly for the postgraduates, for examination going postgraduates, because these are some of the questions that may be asked in your Viva sessions and clinical examinations. This topic may help you in answering these type of questions. My topic is what now here. This is my This is my topic. That means I'm going to tell in ophthalmology, there are certain things never to be done or never will be seen or never occur. These things, based on that, I selected a topic called never, so that you can easily understand, you can easily answer in the examinations. And this dialogue, or there is a famous person, cine actor, Shivaji Ganesan, in his movie in 1973, in one movie, he was using this dialogue, of course, in a song. So it kindled interest in me, so that I could find, or I could read ophthalmology to find out whether there are some nevers in ophthalmology, to stress the importance, so that these things will never happen. These things will never occur. Like that in ophthalmology, there are certain points, or there are certain conditions I can tell you now, you can understand. Now we see, we have got, this is the classical case of retinoblastoma tumors. Retinoblastoma is what now? It is the most common primary intraocular tumor in children. Never forget that. It's a primary tumor arising from the retinal layers like rods and cones. It's a primary tumor in children. Suppose you're asked, which is the most common primary tumor in the eye? No age is mentioned. Your answer is melanoma choroid. Melanoma choroid is the most common primary tumor, whereas in children, retinoblastomas. In retinoblastoma, there are certain things never, for practical purposes, I'll ask you, doctor, some of the questions. See, retinoblastoma, I told you it starts from where? Rods and cones. The photoreceptors are primitive cells. They can grow into the vitreous. That is called endophytic growth. Or they can go posterior, behind the retina, towards the choroid. They can occupy under the retina, or they spread. So the retina can be lifted, resulting in detachment. That is called exophytic growth. Whereas one more tumor, one more spread is there. They can spread along the retina. It's called planum type. These called growth patterns. Whereas they can spread. See, the growth pattern I told you. They can spread via what? They can spread via optic nerve towards the brain, or they can spread via your blood towards so many distant organs or distant areas, like long bones, skull bones, ribs, sternum. But normally we expect what now? Secondaries means what? We think what? Usually liver. But in this case of retinoblastoma, usually liver are never found in the liver. The secondaries of retinoblastoma are usually not seen in liver. What's the difference now here with melanoma choroid? The melanoma choroid secondaries are commonly seen in liver. That's why when you encounter a patient of melanoma choroid, suppose they ask you in the examinations, you must tell, sir, I would like to do the liver function test. I would like to do the ultrasonogram of the man. Like that you must tell the exam. Same way. So retinoblastoma secondaries are normally not seen in liver. But I told now the growth pattern, endophytic, exophytic growth pattern, I told you. Important point, I will tell you one important point. The growth pattern is there. The tumor is increasing in size, endophytic and exophytic growth increasing. Whereas the planum type, the tumor spreads along the retina. No increase in size. That is why the size is increasing means what? The blood supply may not be sufficient. So the growth increasing means that tumor can undergo necrosis. Once necrosis occurred, followed by calcifications, that is called dystrophic calcifications. You know the meaning of dystrophy? Dystrophy means defective nutrition. Defective nutrition, that's called the literal meaning of the word dystrophy. That's why here necrosis because of nutrition problem, that means the blood supply is cut off, and then followed by calcification. That is why we call this dystrophic calcifications. Now in plain M type, because there is no increase in size, the necrosis and calcification will never be seen in histopathological section of your plain M type. Now the cells of retinoblastoma, they are not closely attached to each other. They can easily break and come to my anterior chamber and float. They are floating. That is called pseudohypopyon. Whereas hypopyon, the pus cells can occur in the case of uveitis, corneal ulcer, uveitis, so many patients. But here, the tumor cell is there. The tumor cells are floating in the vitreous, the anterior chamber, in the anterior, in the aqueous, is called pseudohypopyon. This problem, pseudohypopyon, can be more commonly seen in retinoblastoma tumors. Whereas in melanoma choroid, the pseudohypopyon usually not seen, because the cells are the factor called, that factor is called as cohesive factor. So the cohesive factor is very high in melanoma choroid. They cannot break and come to anterior chamber. That's why pseudohypopyon never seen in melanoma choroid. Whereas secondaries, I told you, via blood, take distant areas. Well, suppose I take a biopsy from secondary area, that metastatic site. So imagine from a bone, I take a section of the tumor, the secondary tumor. Now this tumor has got abundant blood supply. Abundant blood supply is there. So necrosis and calcification will never be seen in secondary sites of the retinoblastoma tumors. Never forget, these are all some of the classical viva questions. Next, once I finish our tumor, I will take you through some regarding pupils. We know I got Horner syndrome, the sympathetic palsy. The sympathetic nerve supplies your dilator muscle. The parasympathetic nerve via third cranial nerve supplies your constrictor muscle. You know, everyone knows this. Whereas, what is cocaine? Cocaine, it is behaving like a sympathetic mimetic. That means what is acting like a epinephrine, norepinephrine. How? It's not a direct effect. It's not a direct acting drug. What happens normally? The norepinephrine coming out of the postganglionic area, okay, it has to be destroyed. How it is getting destroyed? There are so many ways. We have got MAO, monoamine oxidase is there. Catechol-O-methyl transferase, COMT is there. And one more method of destruction is reuptake. Reuptake in the nerve endings. Reuptake. Now, cocaine acts how as a sympathetic mimetic. This reuptake is prevented by your cocaine. That means what? More amount of norepinephrine can remain there. So they can work as a sympathetic system stimulant or sympathetic mimetic. What's happening in Horner syndrome? It's a Horner syndrome, sympathetic palsy. Sympathetic system is involved. So norepinephrine may not come out. There is nothing is outside. So naturally, when you apply cocaine in the patient of Horner syndrome, normally what happens now? The cocaine, when you apply, I told you reuptake is prevented, can remain more norepinephrine can remain, and the dilator muscle can dilate. The dilator muscle supplied by sympathetics, dilator muscles supplied by sympathetic is dilated. They can dilate. Whereas here in sympathetic palsy, there is no norepinephrine outside. Cocaine has got no role. That is what I want to tell here. Cocaine never dilates Horner's people, whereas the normal people, yes, they can dilate. One more point, again an exam question for postgraduates. Now you got there are so many pathways. Sympathetic system has got a first order, second order, so many things are there. We've got a preganglionic and postganglionic fibers. Preganglion is what now? Superior cervical ganglion. Superior cervical ganglion is a ganglion. Before that, it is preganglionic. After that, it's called postganglionic. Just know this. This pathway is anywhere. You can easily assess. You can easily tell the area. But the problem is what now? I want to know any pharmacological test is there. I want to know whether the preganglionic area before the superior cervical ganglion is involved or the postganglionic area is involved in the pathway. It's a classical question now. For exam purpose, now we are using what is called hydroxyamphetamine. Hydroxyamphetamine drops. You can use it and find out, or you can differentiate. The problem is preganglionic or postganglionic. That is before superior cervical ganglion, cervical ganglion, or post superior cervical ganglion. The areas. Now I'll tell you. Normal circumstance, what happens? Normal circumstance, what happens is when you have a problem in preganglionic area. Preganglionic area means before ganglion, sympathetic ganglion. Yeah, problem is there. Now you have got a problem is what now? The norepinephrine is manufactured and remaining within the postganglionic area. Preganglionic area problem is there. Norepinephrine is manufactured, remains in the postganglionic area, not able to come out. Not able to come out. Whereas if you got a postganglionic area problem is there, a lesion is there. Norepinephrine not all manufactured. Nothing is inside the nerves. Just know this point. This difference, if you know, you can easily understand. Now, I already told now, preganglionic problem is there. Preganglionic problem is there. Norepinephrine manufactured, remain within the postganglionic area, not able to come out. Whereas a postganglionic area, not all manufactured. I'm going to utilize this to differentiate. The problem is in pre or postganglionic areas. I'm going to apply hydroxyamphetamine. How this hydroxyamphetamine works? This hydroxyamphetamine enters the postganglionic area, nerves, enters the postganglionic nerves and push something from inside to outside. And what is inside it, they can come out and act on the your people. The dilator muscle, they can act. Whereas in preganglionic, I told you, preganglionic area, norepinephrine manufactured, remains in the postganglionic area. Now your hydroxyamphetamine enters inside, push it, the norepinephrine can come out, the people can dilate. Whereas in the postganglionic area, nothing is there, norepinephrine not all manufactured. So your hydroxyamphetamine enter inside, nothing is there inside, they cannot dilate your people. That is why I've given here hydroxyamphetamine eye drops never dilate where postganglionic corner syndromes. Postganglionic, like for example, exam question, where is the postganglionic area? They will ask you, sir, classical example, your cavernous sinus areas, that's all. Cavernous sinus areas only you can tell in the exams. Or carotid artery area, above the common carotid artery bifurcations. You can tell above the common carotid artery bifurcations. These are the areas, postganglionic areas. When you have a problem with cavernous sinus, when you apply hydroxyamphetamine, people will not dilate. Whereas when you have a problem in spinal cord area, when you apply hydroxyamphetamine, people will dilate. These are called preganglionic areas. Now, one more importance for the management part. We get sometimes, very rarely, we get after cataract surgery, whatever thing is there, you can have endophthalmitis, inflammation inside the vitreous. That is called, that means endophthalmitis is what now? Inflammation of the intraocular cavities. They will ask in exams, what is endophthalmitis? Your answer should be, sir, inflammation or infection of the intraocular cavities and its surrounding structures like retina and choroid, but not involving sclera. If sclera is involved, it's called panophthalmitis. That's all. Now, when you treat a patient with endophthalmitis, there are so many indications that, but now we are going to, suppose I want to give intravitreal antibiotics. We have got gentamicin, 1 ml 40 milligram is there. 1 ml 40 milligram is there, injection gentamicins or amikacin, whatever thing is there. 1 ml has got so many milligrams. But I have to give how much now? I have to give only 0.1 ml. I cannot give more than that into the vitreous. But if I suppose, for example, 1 ml has got 40 milligram of gentamicin. If I take 0.1 is 4 milligrams. If I take 0.1 ml of gentamicin, it's 4 milligrams. I should not. I should inject only 0.1 milligram into the vitreous. That means I have dilute and give. Dilute and give only. I cannot give straight away injection, gentamicin. From there I take 0.1 and I cannot inject. The problem is what? When you give undiluted gentamicin in the vitreous, never forget, when I give undiluted medications, undiluted, they can produce what is called infarction of your macula, the retina vessel getting destroyed. That is why infarction of macula can occur. That is why undiluted gentamicin should never into the vitreous. Similarly, I've got in the vitreous, Teria solium, the larva may be floating in the vitreous sometimes. Now, if I give drugs to kill the larva, what will happen now? Suppose I give drugs to orally to the patient. What will happen now? That cysticercus may die, but when it dies, it produces severe inflammations, and the eye will be lost. That's why better, no drug to give in a cysticercus or the vitreous. What to do now? Your answer is, sir, better is I will do a pars plana vitrectomy. Vitrectomy I do. Pars plana vitrectomy and remove the cyst in toto. We have to remove the entire cyst without rupture. That's the most important point for exam purpose. Now, we've got sympathetic ophthalmia. What is sympathetic ophthalmia? Everyone knows. What is sympathetic ophthalmia? It's a bilateral granulomatous inflammations. Bilateral granulomatous inflammations of the uvea. Understand now? Why it occurs now? Answer is occurring because of injury to one eye. Suppose right eye is injured about few months back. Now the fellow will develop left eye uveitis. Left eye uveitis will develop. But never forget, when it develops sympathetic ophthalmia, never forget, both eyes will show signs of inflammations. It should show. Even the eye may be phthysical, man. The injured eye may be phthysic. So very small eye would have gone out of the function, may be lost. But still, the phthisis bulbi, the phthysical eye, the small eye, may show signs of inflammations when sympathetic ophthalmia starts. That is why I call it as bilateral granulomatous uveitis, occurring as a result of injury to one eye. It may start even 1 month or 2 months later also, doesn't matter. But what's the difference now? Is it granulomatous? I told you it's a granulomat. That means what? We can have lymphocytes, epithelial cells, giant cells, so many things. Similarly, I got one more problem, what? Tuberculosis uveitis, choroiditis. They can also show granulomatous inflammations. The choroid of sympathetic ophthalmia also will show granulomatous inflammations. Now, exam question is what? How do you differentiate, doctor? How do you differentiate? Is it a sympathetic ophthalmia choroid, or is it some case of tuberculosis choroid? They will ask you. Your answer is, sir, when I examine histopathology, the Brooks membrane, which is a part of choroid, is never destroyed in the case of sympathetic ophthalmia, whereas in tuberculosis, yes, they are involved. And choroid is what? Full of blood supply only, blood vessels. Choroid capillaries, medium sized, large vessels, so many vessels are there. Now, the choroid capillaries are never involved in sympathetic ophthalmia, whereas they're definitely involved in tuberculosis cases. There's a classical difference. When you're asked in examinations, how do you differentiate a sympathetic ophthalmia choroid from a tuberculosis choroid? Your answer is, sir, Brooks membrane intact and choroid capillaries intact. They are never involved. That's what I've told here. Choroid capillaries never involved sympathetic ophthalmia, never. Brooks membrane never involved in sympathetic ophthalmia. These are some of the classical exam questions. Never forget again. Now you see, this is called coloboma. These words called coloboma choroid. Sorry, lens. Can you see now here the lens? This is the lens coloboma. That lens is not something. Some areas defective. And you see now here got it's a nucleus and the cortex become liquefied. It's called hypermature. Everyone knows it's hypermature cataract. Hypermature Margagian cataract. Everyone knows it. The cataract. The coloboma is what now? Defect. The coloboma in normally we see where maybe iris, maybe choroid, maybe optic disc. These areas normally we see. All these things happening because of what? Because of what? The embryonic fissure that is in lower nasal quadrant. The lower nasal quadrant development, lower nasal quadrant, embryonic fissure that is there. Normally, never forget, normally starts by 6th week of gestation and closes by 8th week of gestation. The life of embryonic fissure is only 2 weeks. So starts by 6th week and closes by 8th week. If it is not closing properly, you can have a defect in the development of structures, particularly where in the lower nasal area. Iris may be defective, choroid may be defective, optic disc I can have a coloboma. But now they will ask, what about the lens coloboma? Lens coloboma is because of what? Is it because of embryonic fissure? Your answer is no. Lens coloboma never due to embryonic fissure. Then what? How is it problem? What's the reason for this development of lens coloboma? Your answer is, sir, it is because of defective development of suspensory ligament of the lens, otherwise called zonules of the lens, which are extending from your ciliary body area and holding that lens in place. These zonules are defective in some area. That area become defective. So lens coloboma is because of zonules, improper development of zonules. Never forget this point again. A classical exam question again. Now, you know we have got cortical cataract. The cataract is there, cortical cataract. The cortical cataract is different stages. You can have immature, mature, hypermature. So many stages are there. Whereas a nuclear cataract, there is no stage of hypermaturity. Whereas nuclear cortical cataract, I can have so many, the hypermaturity is like this. I was showing this picture. This picture is like this. It's hypermature cataract. So nuclear cataract never hypermatures. Now subluxation of, the lens is displaced. The lens subluxation, that means it can go upwards in a Marfans. It can come downwards in a case of homocystinuria. That is defect of cystathionine synthetase. Cystathionine synthetase enzyme deficiency. That is homocystinuria can occur. Now what happens in this case now? Marfans usually upwards and outwards. Homocystinuria displacement of the lens is usually downwards and inwards, down and in. But what's the beauty now? In Marfans, the zonules are intact. The suspensory ligament is intact. Only the length has changed. That is why lens in Marfans will change shape. They can change shape during accommodation. Whereas in homocystinuria, the lens zonules are all disorganized or degenerated. That is why they can never take part in accommodation. That's what I have given. Accommodation never takes place in homocystinuria. Whereas in Marfans, yes, they can take place. These are common. Again, exam question again, for example. Now, one more point. When you take optic nerve, because it's everyone knows a misnomer. Optic nerve is not a nerve. It's only a white fiber tract connecting second order neuron like ganglion cells in the retina, and third order is in lateral geniculate body, LGB, lateral geniculate body. So it's only a white fiber tract. When it is damaged, it cannot regenerate. And moreover, it has got no neural lemma. It has got no neural lemma. Neural lemma is called neural lemma. Neural lemma has to be there for its growth, regenerations. So optic nerve is not a nerve. Optic nerve has got no neural lemma, neuri, N-E-U-R-I, neural lemma. So it can never regenerate when damaged. And moreover, see, when I have got third nerve, fourth nerve, whatever nerve is there, third nerve problem is there. When it improves, they can have regeneration of nerve because they have got neural lemma. They can regenerate. Whereas in diabetic patients, it's also an exam question. Diabetic patient, third nerve palsy, don't tell the examination that they can have regenerations, aberrant regeneration, they can never occur. Whereas an aneurysm, a tumor mass, compressing third nerve, they can develop aberrant regeneration, they regenerate when they regenerate, they can develop. Whereas a diabetic patients, they can never develop apparent regenerations when they heal, when the problem improves. Of course, there are some of the drugs which are using in glaucoma patients. Timolol is a non-specific beta blocker, so it can act both on cardiac system as well as respiratory systems. That is why never used in asthmatics. Acetazolamide, they can decrease secretion of aqueous, and it is a sulfur drug. They can develop a problem for sulfur patients, allergic patients. So acetazolamide never used in sulfur allergic patients. Adrenaline eye drops, should not be used in aphakic patients. You know why? See, aphakic patient is there. There's a lens is not there. What's happening here? A person normally, when he have, understand now, suppose I'm using adrenaline or epinephrine. These epinephrine drops can go into the eye, sensitize your macular retina, that is macular area. The cells in the macular area, they can get sensitized, or the area of the macula gets sensitized. The same fellow, imagine now, that goes outside. A normal person, imagine a normal person going outside. The sun rays, the ultraviolet ray from sun can enter your eye, enter into the area, it reach the area of the retina and stimulate again. Where? In an aphakic patient. Whereas a normal person, what happens now? The sun rays, the ultraviolet ray enters your eye, the normal person, never forget. The normal person, the ultraviolet ray enters inside, the lens can absorb. They cannot reach the retina. Whereas in an aphakic patient, when the lens is not there, the ultraviolet rays from sun can easily enter your retina. Already is producing, already the macular cells are sensitized by adrenaline, sensitized. Now again UV rays and go, again stimulate, and they can have edema. Or edema can develop in the macula. This is called epinephrine maculopathy. That is why we are not supposed to use epinephrine in aphakia patients. One more, metipranolol. It's a beta blocker, non-specific beta blocker, non-specific. But the drug itself can induce uveitis, the side effect. That is why you are not supposed to use in uveitis patients. IV mannitol, this also for reducing intraocular pressure. IV mannitol, how does it help now? When you increase and IV intravenous mannitol, the osmotic pressure within the blood is increased. The osmotic pressure within the blood is increased. Now the osmotic pressure in the choroid, it's the blood vessel I told you, choroid is full of blood vessels. So naturally the osmotic pressure in the choroid is increased. When the osmotic pressure is increased in the blood vessels, now inside the blood column, naturally the fluid from the eye, that is vitreous is 99% water. The water is absorbed from vitreous. It enters your blood, choroidal blood. So naturally the vitreous shrinks. It's called vitreous shrinkage or detergit, or dehydration of the vitreous takes place. Now the vitreous shrinks, the intraocular pressure comes down. That's the way they're working. Imagine now, this is what the case. Now, in a case of glaucoma, you're going to give to reduce the intraocular pressure. But what's the problem? Side effect is now the mannitol not only reducing your vitreous dehydration, producing vitreous dehydration, they can enter your brain, the thirst center in the brain also dehydrated. The thirst center is dehydrated thirst. The thirst center is brain is dehydrated. You will have intense thirst. You will keep on asking for water. You will keep on asking for water. Your answer is water, no, never to be given after IV mannitol. The reason is when I give mannitol, the water can enter your blood circulations. The osmotic pressure is decreased by your water. So the desired effect on the vitreous cannot take place. That means vitreous cannot shrink. That's why the water nullifies the effect of your mannitol. That's why water, oral fluids, whatever thing is orally, no, never after IV mannitol. Now there are few things. You might have heard about hypermetropes. Normally they tell what they can see distance, they can see near. Like that they can tell them hypermetropes can see distance, myopia can see near. Like this we can tell. But it's the wrong notation. It's the notion. What's happening here? Hypermetropes, the paralysis of light, When the eye is at rest, that means not accommodating, comes and back, falls behind the retina. Parallel means what? Coming from distance. When the rays from distance are falling behind the retina, the near also will further behind only. That means hypermetropes cannot see distance, cannot see near also, unless he accommodates. That is why hypermetropes, when you accommodate, the lens is going to change the shape and converge the rays. The rays from distance can converge on the retina to a certain extent. Not in high powers, for mild power, that's all. Maybe 2 or 3 powers. They can see distance by accommodation effort. That is called hypermetropes never see distance without accommodating. You know what is X-linked dominant lesions? X-linked. You have got X-linked, you know, or some dominant, recessive, sporadic, you know, X-linked, recessive, dominant. Like that we got maternal mitochondrial. There are so many inheritance patterns. But X-linked recessive, never forget one point, X-linked recessive, females are carriers, manifest in males. Whereas X-linked dominant means what? Male has got a chromosome XY, X-linked dominant chromosome is there. The fellow, if X-linked dominant problem is there in the patient, male child, the child will not see its first birthday itself. It may die. Very rare to survive. That is why X-linked dominant lesions, suppose you come across at X-linked dominant patients, if you will see mainly in females, not in males. The males will not see their first birthday. Example, incontinent pigmenti. We have got one more thing is called, there's a classical again exam question for postgraduates. It's called Aicardi syndrome. Aicardi syndrome. Aicardi syndromes. What is Aicardi syndrome? Lacunae, lacuna formations in the choroid, in the retina, and the brain. They have neurological problems also. That is called Aicardi syndrome. Aicardi syndrome, X-linked dominant. The incontinent pigmenti, they can develop problems in the retina, which is also a differential diagnosis for retinoblastoma leukocoria, white people. With a differential diagnosis for retinoblastoma, leukocoria, white people, leukocoria. Leukocoria, that's a classical example. Leukocoria is, we have got leukocoria. Coria means, you know, people. Leukocoria. That means what? X-linked dominant patients or dominant lesions never be seen in adult males. Don't make a diagnosis. Similarly, I can have inflammatory problems, both eyes, proptosis. Inflammatory problem is there, unilateral. You can make some diagnosis of idiopathic orbital inflammations, idiopathic, that's called pseudotumors. But usually bilateral pseudotumor, otherwise idiopathic orbital inflammation, idiopathic orbital inflammations, that's called pseudotumors, will never be seen in adults. Never make a diagnosis. Never make a diagnosis of pseudotumors bilateral or idiopathic orbital inflammations in bilateral. Very, very, very rare, remote chance. Similarly, you know, follicles, collection of lymphocytes. But in, you know, we got vernal catarrh, spring catarrh, or allergic manifestation exogenous proteins. What's the problem here? What is follicles now? I told you. Follicles are lymphocytes in the subepithelial adenoid layer of conjunctiva, under the conjunctiva. Please remember, this adenoid layer is called adenoid layer, develops 3 months after birth only. That means what? The child is born today, 3 months later only you can see adenoid layer. Only when there's adenoid layer is there, I can develop follicles. So before 3 months, never make a diagnosis patient having follicles. That means what? Follicles never occur before 3 months of age because the adenoid layer is not developed. Similarly, vernal catarrh, allergic manifestations for, you know, outside pollen, exogenous proteins. They can develop papilla. What is papilla? Hyperplasia of capillaries and sometimes new capillary formations. So what is papilla? Papilla classically occur in spring catarrh or vernal catarrh. Vernal catarrh is what now is a seasonal problems, but not in India. Please remember, our country can occur any time. In our country, it can occur anytime. But the problem is what? Allergic manifestation of exogenous proteins, and never make a diagnosis. I've seen students committing mistakes. Never make a diagnosis. Papilla can be seen in vernal catarrh. Follicles will never be seen. Never occur. Never occur. If I got follicle and papilla together in a same patient, it has to be trachoma, chlamydia infections. Trachoma, chlamydia infections is a classical. Never make a diagnosis of follicles in vernal catarrh. You can easily get caught in exams. And of course, fungus steroids, no, in fungal ulcers. In keratoconus patients, see, in keratoconus patient is there. Suppose I'm having a keratoconus patient like this. This is a cone. It's a cone. If I put a soft contact lens alone, the soft contact lens come and take the shape of the cone. The cone is not abolished. That means what? Keratoconus patient, if at all I want to give rigid contact lenses, rigid, soft lenses alone. I'm not telling soft. We have got so many lenses there. Soft lenses alone, never. In keratoconus, if I want to use soft lens alone, if you want to use a soft lens also, your answer is, sir, yes, I can, sir, put a soft lens, over which I can put rigid. They can take it off. It's called piggyback lens. It's called piggyback. It's called piggyback lenses. Piggyback lenses. Piggyback. BACK. Piggyback lenses. That means what? Soft lenses alone, never in keratoconus patients. If at all I want to use a soft lens, I have to put a soft lens over which I have to apply a rigid lens. Never forget this point. Of course, Toxoplasma, you have to give Toxoplasma, anti-Toxoplasma drug, anti-Toxoplasma drugs like pyrimethamine, atavacone. Some drugs are there. You have to give triple sulfur, and then only steroids. Never give steroids alone because inflammation is there. And then when you have a AIDS patient is there, no steroid. You know that, no steroids. So naturally, Toxoplasma can occur in normal person as well as in AIDS patient also. So Toxoplasma in normal person, you can give steroids, but yet it has to be combined with anti-Toxoplasma. Whereas a Toxoplasma in AIDS patient, no steroid at all, nothing. Same thing, pyrimethamine. Normally we give for normal persons. Pyrimethamine can produce a bone marrow suppressor. It's a bone marrow suppressor. It's a bone marrow suppressor. So naturally, better to avoid Toxoplasma patients in AIDS. Better to avoid pyrimethamine. Now there are some arteries. You know, you got one artery here. Can you see this artery? This is called deep optic artery. Deep optic artery. And you know one more artery. Can you see this? This artery is called anterior choroidal. Just because the name is there, don't get confused. Deep optic artery supplies your radiations. Is a branch of middle cerebral. Anterior choroidal artery is a branch of internal carotid. Supplies your optic tract, lateral geniculate body, some part of radiations. That means what? Deep optic artery supplies your optic radiation. It's a branch from middle cerebral artery. That's why given. Just because an optic nerve name is that, don't tell optic nerve. I've seen students telling now it supplies which part of the optic nerve. They will tell some nonsense. That's why never use. You always know this. Deep optic artery never supplies optic nerve. It supplies your radiations. Similarly, anterior choroidal artery, because choroid is there, don't tell choroid. Your answer is it supplies tract and all. That's why it never supplies choroid. These are some of the tricky questions. Never. Nerves are never ending in ophthalmology. We can have so many nerves. We can collect yourself. When you read, try to read all those things. When you collect all the nerves in ophthalmology like this, there are certain sentences also you can collect. Pathognomonics. There are some pathognomonics in ophthalmology. For example, I'll tell you, list nodule, pathognomonic of neurofibromatosis. List nodule, pathognomonic of neurofibromatosis. Similarly, dendritic ulcer with a bulb-like expansion, bulb, B-U-L-B, bulb-like expansions, pathognomonic of hip simplex. Like that, no, we got so many pathognomonics also there. You can collect, when you read, you can collect all these points. So at least you will remember things better. That's why always remember, reading, you have to read, then tell others also. That's the most important point. When you read, you disseminate your knowledge also. Thank you very much for this patient hearing. Thank you.